Good afternoon, everyone. How are you? We're going to move to the big picture now for just a little while. That's how my talk is focused: reinventing public health in the era of AI, harnessing information to expand lung screening and to save lives. I think we have a formidable challenge before us. I think any of you in the audience that were also in Madrid remember some of the discussion that we had there. So this map is a map of the world, and it gives you the percentage of people who are presently smoking as of 2021, who are age 15 or higher. And that little graph there goes from 0% to 37%. If this were broken out between men and women, it is not. That's a blend. We'd have a higher risk rate there. So in other words, more men smoke than 37% in many places, sadly. What does this mean? It means, if you remember the slide we saw earlier today about the tsunami, we have a coming tsunami of lung cancer and of all of the other smoking related illnesses, and of course, of the other causes of lung cancer, which in some places are becoming more prominent because of the decline for those who are at the other end of the tsunami, like the United States, with respect to lung cancer. But the tsunami is still waiting to come in some places based on them having reached their peak in smoking fairly recently. And it is still yet to come in countries whose actual tobacco baseline rate and their population rate are still stabilizing, in that in some countries population is declining, surprisingly so, and in others it's rising at a lower rate than had previously been expected. All of those dynamics will affect the size and the nature of the tobacco related illness tsunami. The next slide, if I can, looks again, and we talked about this in Madrid. We don't use the term developed countries, underdeveloped countries. We use now low middle income countries and also the Human Development Index. So these circles are based on the Human Development Index. They're male and female. I have one main take home message from this. If you look at the percentage of the very high Human Development Index for how many smokers there are, you'll see for men, 20% and 53%. Distribution of smokers. Blah, blah, blah. Okay, I'm confusing myself. But basically, the opportunity that is there for the tobacco industry is enormous with respect to women. And so if we think that we've seen the peak in many countries, we have not, because we have many countries in which very low proportions of women smoke. And the numbers that are smoking are rising while they are falling among men and among other populations, including countries where we've gone from 0 adolescents to 1% adolescents to as much as 14% of adolescents in as little as 5 or 6 years. So again, the nature of the tsunami remains largely unpredictable due to a number of factors. And one of those factors is the extent to which the tobacco industry will endeavor to get the market that they're not getting. And an example is that I always like to give is a Philip Morris ad showing a beautiful African woman in African garb, and across her neck, written in Swahili, the following sentence: "Find your voice." That was a shot heard around the world because, of course, smoking is one of the primary ways that women will lose their voice. But in Africa, some 4 countries have Swahili as their main language, another 14 speak it. This was a very powerful ad from Philip Morris moving through Africa to try to get a population whose smoking rates were exceptionally low. Next. By country, countries with the most smokers from the bottom up, as you can see. This has been a problem originally largely of high income countries, but it has moved into low and middle income countries substantially. And again, this is a building tsunami in countries where the access to care is even lower, and the ability to marshal screening resources probably also will remain lower. So in this particular overview, I just want to bring home a few key points, and that is globally in 2019, 1.4 billion individuals were current smokers. It's a little bit higher than that right now. It's 1 in 8, one in 8 world smoking prevalence. That translates into tobacco accounting for 7.69 million deaths and 200 million disability life years per year. It is the leading risk factor for death worldwide. It has been the leading cause of death worldwide since I entered public health in about, let's see, how back, 1974, 75. So that's many, many years ago, and it has not lost its place yet as the leading cause of tobacco-related death. It's distributed in various ways. This is a distribution of smoking among males. And the color code is simply the dark red and the greens are the higher rates, and the yellow and the blues are the lower rates. And as you can see, the epidemic is waning in certain parts of the world that used to have very high smoking rates and building up in other parts of the world. And the same is also true for women as well. And this one shows the actual code, proportion of all-cause deaths that are related to tobacco. In the blue, it's under 5%. And in the red, of which there's very little on the female slide, but if we were to go back to the male, there's more red there. In the red, you see that it is 30 to 35% of all deaths caused by tobacco, which kind of startles people, understandably. And then by country, the incidence and the mortality. I always, in presenting this to a public health audience, I first let everyone know that in the last century, 100 million people died of tobacco. And then I say, how many people do you think are going to die in this century? And I let everyone guess in the class. And never, not once yet, have I gotten the right answer. In this audience, I know the right answer is here. What's the right answer? Pardon? No, how many people will die of tobacco-related causes in this century versus the 100 million that died in the last century? Well, way more. The question is, how much more? Okay, I'm not hearing the answer, Harold. Yes, exactly right. Over 1 billion. Who said over 1 billion? Take a bow. Because it's an answer that very few people know. I want to just state that right off the bat. And it's also very helpful when you're explaining an epidemiologic problem to a school of public health class, is to have them understand the correlation between incidence and mortality. Not only how many people get it, die of it, which is of course very high with lung cancer, they're getting somewhat more optimistic, but also the framework within which that happens. If it's Ebola, it's close to 100% within a very short time frame. If it's lung cancer, it's within a few years if you're stage 4, if you're not lucky enough to be getting the absolute highest quality of care. So now, key areas of key AI currently being applied in public health. Public health treats the population. Those of you who are clinicians in this room treat the individual. Everything you do as clinicians affects population health, and everything population health does in terms of its decision-making, which would be something like, how do the insurance companies cover screening or not, and which groups do they cover? That is, quote, the public health policy level. AI is becoming a very important tool within public health, but there is considerable suspicion about it within public health because of the extent to which, if they get it wrong in a big way. And so these categories, those are the core categories of what the field of public health is responsible for in the United States of America: health promotion, health surveillance, health protection, population health assessment, disease and injury prevention, emergency prediction, preparedness, and response. I've left it out of this discussion, the last one, because I don't think it's terribly relevant to what we're talking about today. But health promotion, policies and services to maximize cessation with AI tools. We just heard a little bit about that. And we also heard about it in relation to dietary modification. The development of those tools will be extraordinarily important with respect to the work that you plan on doing with an integrated CT, with respect to demonstrating the actual cost benefit or cost effectiveness of that integrated strategy. Because if you have the integrated strategy, and yes, you do a surgical intervention on lung cancer one time because someone's stage whatever, and that person goes right back out and continues to smoke and stops bothering to screen, you have a whole other cost benefit than if you are actually able to integrate that person into a system that will stay with them for as long as it takes for them to quit. I will make one point here right now, because I've heard the term lifestyle factors and behavioral factors multiple times since I came here. You rarely hear those words within a school of public health. And the reason you don't is that the theoretical underpinnings of public health have evolved to think in terms of the social determinants of health, and the data have suggested that these simple lifestyle changes, even the concept of simple lifestyle changes, in reality, it is not simple. It does not happen easily. And just even in my period as leading a foundation dedicated to reducing smoking in America, the fact that I kept driving home that nicotine was addictive and that indeed it is considered the most addictive substance known to humankind reframed the way people felt about their own addiction to nicotine and to various tobacco products. And it also reframed the way their family thought about them. So the one thing that I would say is, as you take on this big challenge of doing this screening that integrates multiple illnesses, and then you say, okay, now we know you're at risk for this, you're at risk for that, you're at risk for that. Here's how we want you to change. You cannot manage that on your own. And I've heard some people say you can't because of time and reimbursement. Fine. But even if you had all the time and reimbursement in the world, it would not be something that you would want to manage, because it is not an easy task. Changing people's weight. In fact, you probably all know the literature, short of the new miracle drugs that we see now, making that change extremely difficult. The metabolism recalibrates, and at a much lower caloric level, still continues to keep its weight. It creates a new homeostasis, and it adopts that homeostasis and moves forward. So all of these things are extremely complicated. And then I'll add one more that, as I was putting it together, I thought it's really important to make this point. The people who still smoke in the world, particularly in the high-income countries, that behavior is highly correlated with poor diet, substance use, and independent of the substance use, excessive alcohol use. And so you are going to find, when you start doing your studies, very high collinearity between all of these problems. So it's not just that there's a behavioral target that needs to be addressed. There could be multiple simultaneous behavioral targets to address. And I don't need to tell you, I'm sure you can imagine on your own how complex that is. I raise that because I think the AI tools are extraordinary additions to our ability to be able to manage that, manage it in a cost-effective way, manage it in a fairly relentless way, study the impact of being relentless, because at some point someone shuts you down and says, I don't want your messages anymore, I don't want your calls, I don't want your advice. But we have seen great effect with these tools. I'll give you one example developed by our own group at Legacy and then also at NYU, is taking someone who quit smoking and giving them a tool where they can never walk by a store that's selling cigarettes, which previously and in most states still are plastered with advertisements for various brands on the front of the store. In some jurisdictions that's not permitted, but in many parts of the country, the South in particular, is still very common. So that was a great advantage for people who were trying to quit smoking, to not have to walk by where they could buy cigarettes 15 times a day in any given day. Health surveillance, integrated databases to assess patterns and prevalence of smoking. So we not only need to know who is smoking, we need to know where they're smoking, how much they're smoking, why they're smoking. And then we have a whole new pattern emerging in terms of the pattern of the disease pattern associated with smoking, because people are doing a mix of different products. Health protection, assessing policies that work through AI tools. I'll give you a great example. I work for the White House Office of Drug Control Policy. Yesterday, it was announced there was a near 11% one-year decline in opioid-related deaths. Yes, don't clap too soon, because there are some reasons why it may be correct. There are some reasons why it may be higher than it is. However, in the period in which that happened, as a result of efforts undertaken by the Biden administration, multiple policy changes happened all at once. That's an AI problem of considerable import. So you have 50 states, 50 different opioid epidemic trajectories, 50 different rates of decline or increase that occurred during that 12 months. And nothing would be more wonderful than to be able to say, of those 10 initiatives that happened all over the country and were implemented at various levels in different places, which one or ones in what combination are really driving this decline. There are anecdotal explanations about what's driving it. Naloxone becoming OTC being one of them. That's lovely, but very large swaths of pharmacies will not stock it. because they don't want those people entering their pharmacy. I would mandate that every pharmacy has to stock it. I wouldn't let them be able to opt out of a life-saving drug, but that's in fact what's happening. So AI can be extraordinarily powerful at the policy and health surveillance level and the health protection level. And then population health assessment, detect the prevalence at the population level and the affinity to the standard of care. Here's a very important issue. I mean, if all of you are doing this kind of screening, what assurance, short of you being involved in a tight study where you must have the assurance to produce the data, in the general practice of your screening, how many of you really know what happened with regard to the risk factor that you're tracking, if you are tracking it, of the patient you advise to do X with their weight, Y with their smoking, Z with their drinking? And the answer is probably very few of you know what happened with those things. And if you do know, you may be, because this is the norm, relying on self-report. I won't say it's notoriously unreliable, but it is definitely somewhat unreliable. So in a sense, it's wonderful to identify the problem, but on the other side of that, you want to understand the solution. Okay, AI. This is a picture of from California. They're not protesting against AI. They're protesting against the death of George Floyd. But the article covered the relationship between discrimination and AI. And I probably am not telling any of you something you don't know, but it is extremely important for us to track how AI algorithms are put together and what inherent problems they may have that can lead to systematic biases associated with them. And the Office of Minority Health at the national level in HHS has had a group that summarized what they viewed as some of the key things that need to occur. If you read up on AI, and I'm no AI expert, as I told David when he asked me to do this talk, you hear about the quote black box, which is the data in, the advice or the conclusions about what should happen out, and how frequently the people involved in implementing the advice on the outer end of that black box cannot explain the logic model of how that truism occurred. Okay, so these are the recommendations to at least begin to take great care in how you approach the application of AI, particularly by creating a system that is systematically biased against women, systematically biased against one minority group or another, systematically biased against an ethnic group that has a different pattern of disease. And it explains how to do it. I won't read them all, but I will say that I think they're critically important to consider. And this example here, I will simply just read from the most important section. For example, and many of you probably saw this paper, it got many headlines. It led to the Commonwealth Fund making a major contribution to watching for this problem. For example, an algorithm used in hospitals to allocate healthcare services to patients in the United States was found to be biased against Black patients. Among Black and white patients who were equally sick, Black patients were assigned lower risk scores and were therefore less likely to receive additional services. This bias arose because the algorithm was designed to predict healthcare costs rather than illness. As Black patients tended to have poorer access to care, they also tend to cost the healthcare system less, and their insurance tends to cover less. And so when you have systems that are seeking to advise on care based on insurability, or you're using data based on the care pattern that was based on insurability, you can have some important systematic difficulties. Then a paper that was written in 2018, let's hope he's wrong for the coming decades. And I know we all know him, Paul Pinsky. While tobacco control remains the most important tool in the long term to decrease morbidity and mortality from lung cancer, LDCT screening, appropriately carried out, has the potential to modestly decrease lung cancer death rates for those countries whose overall resources and healthcare infrastructure are adequate for the task. That was 2018. Our goal, I would assume, is not to settle for modest, but look on the horizon at 2018 as sensible, a modest reduction in wealthy countries. I would say we would love to see, a modest to large reduction everywhere in the world by the application of AI appropriately, um, with appropriate guardrails on the AI, that it's legitimate, it has no systematic biases built into it. Apply that on an international basis in a way that will save lives. What are the things that stand in the way of that? What are the challenges? Resources, resources, resources. It came up over and over, especially in LAMCs where the priorities compete with so many other things, so many other basic things that are not happening. So you're saying, oh, do these special things for people who smoke too much, but that may crowd out vaccines or other basic care for basic services. So that creates a catch-22 and a tension. Demand. People do not know about the option, and healthcare providers are not offering the option, even in wealthy countries. I know that because I know so many recent quitters for whom no one ever mentioned screening to them. They're very shocked when I say you really should get a CT. What is that? Why should I do that? They're not being told, hence the litigation and the class action suits that are starting around this. I think some of you may have seen the ads, which are on constantly in Washington, D.C. Fear, forever an issue, fear and trust, not trusting the system and not wanting to know. These are key issues that are well documented in the literature. Human resources, even in well-off countries, the ability to crank out without the use of a radiologist results for large numbers of scans that you're going to be excluding in this system. That's a great opportunity to conserve human resources and expand what can be done. Disdain for smokers and the myth that it's easy to quit. In essence, blaming them for not only their behavior, quote behavior, but all future illnesses that may flow from it. The current unit cost per screening, which varies greatly across the world. I certainly learned that in Madrid. That's a major obstacle. Everything's relative. If it's $35 in Egypt, it's still a huge amount of money in Egypt, $35 compared to the $300 or $500 it is here. And the guideline itself, in my opinion, and I think that opinion is shared, is too narrow. I'm talking about the federal guideline. A forward-looking strategy, as we discussed at the Madrid meeting, it's critical to increase the yield of actionable information by combined cardiac, lung, and I guess now I'm going to say liver and everything else, osteoporosis screening. An international effort should be organized to make the case for screening and the cost benefits that can accrue when AI is applied to produce this lower cost, including the lower cost of the behavioral interventions, which I think are truly key to demonstrate the efficacy of what you're doing. Assure that AI systems applied do not have any inherent biases that have occurred in other AI systems. And marketing, sort of a dirty word on some level, but I don't feel that way because the foundation I led unsold cigarettes to adolescents really quite effectively. So marketing the concept of screening to patients, their loved ones, policymakers, providers, and insurers. So thank you.